مساء الخير. الصورة دي زي ما انتم شايفينها أبيض وأسود، هي من سنة 2001. مش معناها إن كان أياميها مفيش غير الأبيض وأسود، بس أنا اتعمدت أحطها عشان أقول لكم إن إحنا we started working on UBM since 2001. We were using this instrument, which is the paradigm, and we are still using this instrument. We, all of us who work on UBM or other investigative tools, we're starting the training and كل اللي اتعلمناه في الانفستيجيتيف اوفثالمولوجي الحقيقه اتعلمناه في الاوفثالميك دايجنوستيك اند ليزر يونت في القصر العيني بفضل الدكتوره ليلى عثمان. كان اليو بي ام اساسا بيستخدم 50 ميجا هرتز الترا ساوند ترانسديوسر using a high frequency and producing better resolution and less penetration than the usual ultrasound probe, which is the 10 megahertz probe. 30 megahertz give angle-to-angle image, and when using this instrument, the patient should be lying down using topical anesthesia and with an insertion of a suitable size cups زي اللي احنا شايفينهم في الصورة من تحت, filling with coupling fluid. لكن دلوقتي ظهر other new instruments زي اللي هو هيخلي لنا UBM easier and faster. مش ضروري البيشنت يبقى لاين داون قوي, ممكن يبقى سيمي سيتنج. وهنا ما بنستخدمش كابس ويز فلويد, لكن بنستخدم كفر, ممبرين كفر على البروب. والممبرين ده هو زي ما احنا شايفينه في الصوره هنا في الكابلينج فلويد, وهو بيلمس الكورنيا دايركتلي بلوكال انستيك, على اساس ان احنا بالطريقه دي ممكن نستخدم البروب ده والبيشنت سيمي سيتنج. او another coupling chamber زي اللي احنا شايفينها تحت دي, هي بتبقى very small chamber, وهنا بحتاج احط اجل زي زايلوكريم جل على الكورنيا. يمكن ده هيساعدني اكتر في الاكزامينيشن اوف انفنتس اللي هو اللي تحت, على اساس ان انا بقدر عارفه الدايركشنز بتاعتي سواء كنت راديال او ترانسفيرس, لان احنا هنشوف ان احنا محتاجين قوي في اليو بي ام to know what are our directions. ميزه الطريقه الجديده دي انها بتجيب لي ده 50 ميجا هرتز برو انجل تو انجل اكزامينيشن, لكن عيبه اني انا عشان اشوف الريزوليوشن اللي كنا بنشوفها في الاجهزه القديمه بحتاج ان انا ازوم في المنظر ده, وبالتالي some harming of the resolution. The radial position examination of the UBM بنشوف فيه ان احنا عندنا الكورنيا ما هياش كلير كومبليتلي, لا بيبقى فيها mild reflectivity, وبيبقى عندي شايفه الهاي reflectivity of the Bowman's membrane and Desmond's membrane. ولو احنا مشينا باللاين ده كده بينتهي بينا الى السكليرال سبير, والسكليرال سبير هنا مهم جدا انها تبقى سين انسايد الانجل, لكن مش انسايد قوي, لا يا دوب ناحيه الانجل اساس. الايرس بيبقى مميز بالكونفيجريشن بتاعته بالبيجمنت ابيثيليوم اللي هو هايلي ريفلكتيف تو باك, بالسيلياري بودي هنا, الانتيريور لينس والنيوز واللينس. ده الراديال بوزيشن اللي احنا بنشوفه. لكن الميزه كمان في اليو بي ام ان انا بقدر اعمل وات وي كول ترانسفيرس بوزيشن بهذا الشكل, بحيث ان اقدر اشوف السيلياري بروسيسز واي دامج موجود فيه. بالنسبه للانتيريور سيجمنت او سي تي, الانتيريور سيجمنت او سي تي كان ديسكرايب 1994, وكان باستخدام ويف لانث ده اللي بنستخدمها في الريتينال او سي تي اللي هي 830 نانومتر. طبعا الويف لانث دي ليها ليميتد بنتريشن لان بيحصل لها سكاترنج من التيشوز زي السكليرا. اخترعوا بقى حاجه بلونجر ويف لانث اكتر بمور بنتريشن اللي هي ب 1310 نانومتر عشان تقدر تديني بيتر بنتريشن زي الفيزانتشي. الفيزانتشي which is called Zeiss ميزته انه بيعمل لي better penetration. بنقدر ناخد منه images زي ما احنا شايفين very similar to what we get from the UBM, with the cornea, the angle, the iris, the anterior lens. We can have measurements of the angle width. We can have measurements from angle to angle and wide to wide, as we will see here. And these measurements were very helpful in designing effective IOLs, and it was very important for refractive surgery. We can have what we call anterior segment biometry by measuring the pupil, by measuring from angle to angle and the angles, and the depth of the anterior chamber. Now we are using the retinal spectral domain OCT to have anterior segment OCT. Again, using the shorter wavelengths of 830 to 870 nanometer, and then we'll have the disadvantage of non-penetration of the iris. But we'll benefit from the higher resolution provided by this mechanism of OCT for the examination of the cornea and the conjunctiva. If we compare it with the UBM, we'll have better resolution because we'll have 18 micron versus 25 microns for UBM, and we'll have a faster sampling rate. The patient is seated, upright position, but there is a blockage of the wavelengths by the pigment of the iris. This is an example of using the anterior segment attachment in the RGView OCT, and these are the lenses, one with 5 millimeter depth and one with 2.3 millimeter depth, and they should be attached to the original OCT. Most of the OCTs, of the retinal OCTs performing anterior segment, have this attachment. And this is the difference in the resolution of the cornea with the anterior segment OCT. The applications for anterior segment imaging, including to examine the epibarbar masses, the corneal examination, angle, anterior chamber, iris, anterior lens capsule, posterior chamber in the IOLs or news and ciliary body. If we examine an epibarbar mass like this one with the UBM, we can see that if the mass has a very high reflectivity, it will cause shadowing of the underlying structures, and here we cannot comment if there is invasion or infiltration of the underlying tissues. But if the mass is not having this very high reflectivity, it will show some cystic changes, and we can examine all the underlying tissues, and we can comment then that this mass is a benign mass. But here, with a malignant mass showing total infiltration of the tissues underlying and a very big mass, we can diagnose that this is a malignant mass. Of course, we can't say the histology of the mass. What is the difference if we examine an epibarbar mass with UBM and with OCT? There is no difference. Almost there is no difference. We'll get the same resolution, the same structures, and we won't feel any difference or any priority of an instrument over the other. For the corneal opacities, we'll have post-infectious corneal opacities, post-traumatic, post-surgical corneal dystrophies, or anterior segment dysgenesis. If we are examining a case post-inflammation, we may have corneal opacities like this, a very thick cornea and opaque, with totally adherent iris to the back, or with some corneal synechia like this or like this, or with peripheral anterior synechia and the inflammatory cells in the anterior chamber. And this is unique for UBM. But with anterior segment OCT also, we can see this one with the iris adherent and with the anterior with the lens pushed forward like this. For corneal examination, this is an example to see how can a granular dystrophy appear in UBM. As we see here, we have these opacities with some clear stroma in between. This is with UBM. For macular dystrophy, we have these opacities but the cornea is not clear or the stroma is not clear in between. But when examining with anterior segment OCT, a case of raised macular dystrophy, for example, as we see here, all the subepithelial opacities are very magnified and the epithelium is seen very well harmed by these dystrophic nodules. In salesman nodular degeneration, we can see also how can we see very clearly these excrescences, subepithelial excrescences, and we can measure them. Also, we have more details when examining with anterior segment OCT the cornea. We can see the corneal opacities, different corneal opacities as we see here, and we can measure the thickness in order to plan which type of surgery can we do. We can examine for complication for LASIK, like opacity in the LASIK interface, or we can measure the LASIK flap if we want to do a redo flap, or we can see complications like fluid in the interface, or epithelial ingress and fibrous tissue. We can also see the healing pattern for keratoplasty, and here a case with complicated healing and corneal edema, undulations of the posterior corneal surface. In a case of Descemet's membrane detachment, or like this one, to evaluate intacs and their position if they are eroding the posterior corneal surface or not, and also to examine the lower tiered meniscus in cases to evaluate the dryness of the eye. For the anterior chamber angle examination and glaucoma evaluation with a very high magnification and zooming of the with corneal OCT, we can see the trabecular meshwork and we can see here the canal of Schlemm. Also, we may see the angle like this one, but we also notice that the recess is always hidden by the scleral tissue. We cannot trace the recess here, but we can see also that we have pupillary block or a narrow angle closure. We can also measure the angle opening, but also we see here that we have a hidden recess here. We cannot follow it to the end. In angle closure glaucoma, we can use the OCT to see the pupillary block and to see the effect of peripheral iodectomy and how everything will be better after doing this iodectomy. We can evaluate the OCT also, a filtering lab. We can see the Ahmad valve in the anterior chamber, but we can't follow it backwards from here. But for the UBM, we can follow an Ahmad valve out back to the sclera as its end. The angle examination with the UBM differs better because we can trace just to the recess. We can see the relation of the ciliary body. We can see if there is an angle recession from the scleral spur in a case like this with an eyelid diapse. We may also measure, as we have seen before, angle to angle, and we can see the iris pupil. This for the OCT or the UBM that give us angle-to-angle examination, or with the one which gives us each angle alone like this. We can see different pathology like the plateau iris with the eye with the ciliary body rolled forward like this and pushing the iris like this. The UBM examination to diagnose plateau iris syndrome is very important. Also to diagnose pigment dispersion syndrome. In pigment dispersion syndrome, syndrome, the glaucoma results from the dissemination of pigment granules, and as a result of friction between this surface and the zonules, we'll have this sagging back iris. To diagnose ciliary block glaucoma, it is essential to have the UBM. As we see here, we see that we have a lost AC completely with the lens pushed anteriorly. And as we see, it's a pseudophakic malignant glaucoma rolling the ciliary body anteriorly with the eyelid. The angle recession, or to examine an iris cyst like this one, it will be only seen with UBM. For primary congenital glaucoma, of course, we cannot examine a child with the anterior segment OCT, except if it is a portable OCT. So we need to examine him by UBM with some sedation, and we may use the water bath or the shell, or we may use the contact UBM. And we should know always the shape of the primary congenital glaucoma, which is peculiar for primary congenital glaucoma, and you see this clearer spur right here, headed by the iris and the teeth AC. And if there is a case with severe corneal edema and splitting with the same typical angle recess of the congenital glaucoma, or cases of anterior segment dysgenesis, as we can find here a posterior endotoxin, very small presentation like the histology, or we may find it so exaggerated like this with notching of the cornea, and this is a very thin iris. Or we may see an Axenfeld anomaly, typically like described by the histology, with iris processes extending to the back of the cornea. Or Peters anomaly with the type 1, which is the typical one with the posterior notching, with the iris adherent at the area of intact descents with the deficient descents, like these images. This is the intact descent membrane, and this is the posterior corneal notching. Or atypical cases with multiple notching like this. This was a case which was operated as a primary congenital glaucoma and had hyphema, and post-operatively discovered that this case was Peters anomaly by this intact descents and the posterior notching. In sclerocornea, it's very important to do UBM to estimate the success for keratoplasty. In a case like this, for example, we have congenital aphakia, we have abnormal angular structures, we don't have intact iris, so the results of any surgery will be disappointing. In cases of iris examination for UBM, we can find an iris which is causing posterior synechiae and iris will be like this. We may see all these inflammatory cells with peripheral anterior synechiae. We may see irises in different parts or like this at the pupillary margin. We may examine for iris tumor, whether it is a benign tumor with no invasion or it is a very malignant tumor, or ciliary body tumor pushing the iris like this or invading in the anterior chamber. Or we may see a ciliary body cyst, and this is unique for UBM. We can't see a cyst with an anterior segment OCT. For iridocorneal synechiae, the images here, you can see that we have iridocorneal synechiae like this, extending from the pupillary edge to the back of the cornea. And this will be the same case imaged by the anterior segment OCT. As we see, the resolution of UBM in this case is much higher, and here we can only detect this bulge where the iris is attached. In lens position and cataract after trauma, for example, we can see the relation of the iris to the cornea, and the last we see with the lens pushed forward like this, but also we can see it with the OCT. The ION with UBM is much better because we can see if it is surface fixated when it touches the ciliary body like this, or it is in the back when it is away from the ciliary body like this. Or we can see a broken haptic like this attaching to the back of the cornea and causing chronic inflammation. And we can estimate different parts of the IOL, as we see here in front of the iris, for causing iris adhesions to the back of the cornea, or tilted, or like all these examples. But for the anterior segment OCT, we'll see this open. We'll see the optic. We can't see anything about the optic. So it is nonsense to do anterior segment OCT for IOL. The ciliary body and the ciliary zone is unique for UBM. You can see here ciliochoroidal diffusion with a foreign body, which was very difficult to detect except with UBM, or a case of ciliochoroidal diffusion with inflammatory membrane like this, and the zonules in ectopia lentis. We can't examine them except by UBM and to see this fragmentation of the zonules, or uveitis with cyclitic membrane like this at the zonular area also. Now, what about some cases that could not be diagnosed except with UBM? This case was a female patient taking a drug, now is very common, which is called topiramate or Topamax, and she came complaining of bilateral angle closure glaucoma with severe corneal edema, as we see here, and the descens membrane striated like this, and we didn't diagnose why she has all this pupillary glaucoma and this high tension except by this extreme ciliochoroidal diffusion, and when we searched for, and we found that this was a drug-induced ciliochoroidal diffusion and was mentioned as a complication of this drug. This case was a Lebanese young girl, and she came referred from her doctor as suspecting to have a tumor, which looks here in the slit lamp not like a tumor, it looks like a nucleus of the lens. When we did a UBM, we found that she has an IOL here, but she has another one here. So this won't be seen except with UBM. To see two IOLs like this, one in front of the iris and one behind, and then we saw this nucleus, which is behind the iris, that gives this brownish coloration in the anterior segment, and it wasn't a tumor. And it seems that this patient was subjected to 2 surgeries. This was a child complaining of leukocoria, and as we see, this is the cornea, this is the iris, and this is the lens, and the diagnosis here is tunica vasculosa lentis. This was another child coming with an opaque cornea, and this was his right eye, and as we see here, the typical appearance of the angle, which is primary congenital glaucoma, and the other eye is Peter's anomaly, which means that we may have the 2 pathologies in one patient. This case came with a corneal opacity like this, and we had the UBM. The first impression that you will think that this is the anterior lens capsule, but no, this is the whole cornea with edema and separation of cornea lamella, because this is the lens and this is the iris. And another image to highlight how much the descens membrane can be separated from severe corneal edema like this case. So what is better for UBM? Infants, anterior segment dysgenesis, evaluation of anterior chamber pathology, iris pathology, ciliary body zonule, lens zonules, IOL position, and the angle. So ask for anterior segment OCT when are you searching for detailed corneal pathology in a cooperative patient. If you need angle-to-angle evaluation and measurements, it is better to ask for Byzantine anterior segment OCT or Pentacam or UBM 30 MHz. UBM is specific for examination of the ciliary zone and the zonular area behind the iris. Epibarbar masses and conjunctival pathology may be clarified with higher resolution of anterior segment OCT. Uncooperative pediatric age will need essentially UBM. Thank you.